Assalamu alaikum. I'm Dr. Sumera Jabeen, and we are moving to the last parallel session of today's evening. We would be discussing about obesity and its management. Before introducing our speakers for today's session, I would like to request our chairs to please join us. First chair is Dr. Umar Yousaf Raja. Dr. Umar is currently working as a consultant endocrinologist at Shifa International Hospital and is also the Vice President Punjab of Pakistan Endocrine Society. Dr. Raja has multiple publications and abstracts in international journals. Please, Dr. Raja. Please. Our next chair is Dr. Sarwar Malik. Dr. Sarwar Malik is a consultant endocrinologist and diabetologist. He did his FCPS in endocrinology from Aga Khan University Hospital, and he's currently working as an assistant professor at Ayub Medical and Teaching Hospital. Dr. Sarwar Malik. We're very delighted to have some of the international experts of the subject with us today. Our first talk is role of pharmacotherapy in weight management. And for that, we have with us Dr. Abd Tahrani. Dr. Abd Tahrani is a senior lecturer in metabolic endocrinology and obesity medicine at the University of Birmingham. He is also International Medical Vice President, Medical and Science, Obesity and NASH Clinical Drug Development at Novo Nordisk. Dr. Tahrani has published over 150 reviewed articles and book chapters and in excess of 150 abstracts, and has also several national and international awards.
Hello, everyone. My name is Abd Tahrani. I'm the International Medical Vice President for Obesity Clinical Drug Development at Novo Nordisk, and I'm an honorary senior lecturer at the University of Birmingham in the UK, and a consultant endocrinologist in the University Hospitals of Birmingham NHS Foundation Trust in the UK. I would like to thank the organizing committee of the Pakistan Endocrine Society for allowing me the opportunity to talk to you today about the role of pharmacotherapy, particularly liraglutide 3 milligrams in weight management. I think I would like to start by saying that obesity is a disease, is not a lack of willpower. I know many of us and many people around the world believe that obesity is the person's own fault. I will try to show you during this presentation that obesity is really complex, chronic, multifactorial disease, and that it has nothing with willpower, and that it is driven by biological factors. And these factors interact with the surrounding environment to result in the current obesity pandemic. In order to understand obesity as a disease, I think we need to understand the system that controls energy intake and energy expenditure. And if we think about the eating behavior, there are three components to this system. There is a homeostatic system, a hedonic system, and executive system, all of which contribute to the eating behavior. It must be noted that two of these three systems are actually below the cortex, the homeostatic systems and the hedonic system, both of which are below the cortex. And what that means is that they are actually not under the control of the person or the individual. The homeostatic system determines energy intake and expenditure based on complex neurohormonal mechanisms, where it receives a lot of signals from the periphery. Most of these signals are related to satiety, such as GLP-1, peptide YY, and leptin and insulin, and some of them related to hunger, in particular ghrelin. Based on these signals received by the homeostatic system determines the need for energy intake. This need for energy intake is communicated to the next layer, which is the hedonic system and the motivating system. This system is driven by the wanting, i.e. is driven by the desire to eat, because the homeostatic system told the hedonic system that we need to eat. This system is trainable. So, for example, eating highly processed food will train the system that this highly processed food gives us a lot of pleasure and make us full quickly. And then that will teach that system to seek this type of food, for example. What the hedonic system does, it sends a wave of desire that we need to eat. This wave will have a peak and then it will go down. And it will send it to the next layer. The next layer is the executive function. In the executive function, there is an executive and there is an autopilot. Most of the time, we are functioning on autopilot. So when the autopilot receives this wave, it will determine the action to go and seek food. the executive who can control the autopilot and stop it from seeking food. But the difficulty here is that when in people with obesity, and I'll show you on some of the next slides, that there is basically a problem with satiety. So the problem here, when the homeostatic system is generating lots of signals, these signals, a lot of signals will reach to the hedonic system, then the hedonic system will generate a lot of waves, and these waves will reach to the autopilot and to the executive. Because of the large amount of waves, this executive system at the top get overwhelmed by the number of waves that it reaches to that system, and hence it allows the eating behavior to take place. So a lot of, for example, what we do with lifestyle behavioral intervention is try to control that executive function. But we also need to realize that by controlling the executive function, we mostly have modest weight losses. And that's because the homeostatic and hedonic systems, which are below the cortex, not under the person own control, generate a lot of waves to overcome that executive barrier. And this system is really super accurate, because if we think about how many calories we eat in a whole year, we eat quite a huge amount of calories. And in order to just gain 1 pound, which is half a kilo in a year, there will be only a mismatch of about 4,000 calories in this system. A 4,000 calorie mismatch is basically equivalent to 0.4% error, or about 11 calories a day. So it's difficult to say that just gaining half a kilo, 11 calories a day, or gaining a kilogram, which basically eating about 25 calories a day. And if you think about it, a kilogram per year is a quite significant weight loss, because that will be 20 kilos over 20 years. And all of that is caused by about 25 calories extra per day. 25 calories extra per day are difficult to put down just to willpower. This is a tiny amount of calories compared to how many calories the system handles. And then this is clearly not something that just simply to do with people willpower. And people with obesity have a problem with satiety signaling. So in this nice study, on the x-axis, you will see increasing volume of calories. On the y-axis, you will see peptide YY levels, which is a satiety hormone. The open circles are people of normal weight. The dark circles or closed circles are people with obesity. You can see that whether people have normal weight or obesity, with increasing calories, there is increasing satiety hormone. But you can also see that at each level of calorie intake, people with obesity generate less satiety hormone compared to people without obesity. And what that means is that for someone with obesity to feel the same satiety as somebody without obesity, then they need to eat more. So for example, to get this level of satiety that this normal person can achieve by eating 500 calories and achieve this level of satiety here, the person with obesity has to eat almost double that amount of food to reach the same satiety levels. And this is similar data from GLP-1. This is mixed meal testing. So you can see the time on the x-axis and active GLP-1 levels on the y-axis. GLP-1 is a satiety signal. In people of normal weight, you get a nice response to GLP-1 following a meal. In people with obesity, you get this flat and depressed response, suggesting also impaired satiety signal in people with obesity. Hence, obesity is a chronic disease because it meets the criteria of a disease as outlined by the American Medical Association. The AMA says that a disease must have an impairment of normal function. And we know in obesity, there is appetite dysregulation and there is impairment of physical function. The AMA says that a disease should have symptoms and signs. And in obesity, we know that there are many symptoms and signs related to body fat, joint pain, sweating, tiredness, breathlessness, etc. And the AMA also says that a disease must cause harm or morbidity, and we know that there is more than 200 diseases related to obesity, most commonly type 2 diabetes, cardiovascular disease, cancer, polycystic ovary, NASH, and increased risk of mortality. So obesity fit the definition of a disease. And this homeostatic system, which is sitting in the hypothalamus, receiving all these signals from the periphery, interact with the environment around us. And that results in the increasing prevalence of obesity. And on this very busy slide, what you see here is what the UK government did in about 2007, where they wanted to publish a report called the Foresight Report. In that report, the government wanted to map out all the factors that can lead to obesity. And they wanted to examine all the interactions between these factors. And this report is available freely online for people who want to see it. And what you see on this figure is a lot of circles. Each circle is a factor that can lead to obesity. And each arrow is an interaction between a factor and another. So you see a lot of factors and a lot of interaction. Some of these are driven by biological factors, such as genetics, early life experiences, such as maternal programming, others related to the built environment, the nature of work, such as shift work, for example, the use of technology, food processing and food supply chains, macroeconomic drivers. Social inequalities are big factors in terms of driving obesity pandemic, levels of education, the role of biomedia, and the role of psychological function as well. So a lot of factors interact with the biological factors. Both of these affect the homeostatic system in the hypothalamus, leading to imbalance between energy intake and energy expenditure, leading to obesity. And in Pakistan, there is a lot of obesity. Pakistan ranked 9 in the world in terms of obesity prevalence. About 1/3 of Pakistani adults have either overweight or obesity. And in urban areas, the prevalence of obesity in men is about 23%, and in women is about 40%. However, what is most important to note is that only a tiny fraction of those people with overweight and obesity are actually treated or receiving treatment for their obesity. This could be because of lack of good treatment options. Also, it could be because lack of interest from patients to lose weight, which I can tell you is not usually the reason. Or it could be because also of the obesity stigma, which makes people and healthcare professionals and the wider system prejudiced against people with obesity, because the impression that people with obesity have obesity because of their own fault, not because of the biology and the environment. And as a result of that, there is a barrier in terms of offering the treatment. And it is important to consider that people of South Asian origin are even at increased risk of developing obesity, at an increased risk of developing obesity-related complications compared to white Europeans, even at the same BMI. So this famous picture, which was published in The Lancet at the time, showed a European and a South Asian who have exactly the same body mass index, but the fat mass is hugely different between the two. The South Asian have more than double the amount of body fat compared to the European, despite a similar BMI. And that needs to be considered into account when making treatment decisions for South Asians, where the risk starts at a lower BMI. So I've shown you that obesity is multifactorial, and the reason why it is a chronic disease is because there is currently no cure in most cases, and that in most cases, whatever weight is lost is usually regained. I'll come to that in a minute. However, there is a huge benefit from treating obesity. We may not be able to bring people from obesity to normal weight, but even modest amount of weight losses can have a huge impact on reducing the risk of type 2 diabetes, sleep apnea, osteoarthritis, heart failure, and many, many other complications. So I talked about biological drivers of weight gain and obesity. And it is really, I have very limited time to go into all the details in this talk, but I will focus on two things: explaining the role of genes in terms of weight, in determining people's weight. I will talk about the role of maternal programming, and I will show an example how the environment interact with the genes to produce the person's weight and drive the obesity pandemic. So first of all, if we look at all the genes that have been, or the gene variants that have been related to obesity, and we map them against which organ in the body they affect, we can see that there is one organ that stands out, which is the central nervous system. Indeed, the vast majority of gene variants related to obesity have been linked to the central nervous system, particularly the hypothalamic and the hedonic systems, which I've shown you on previous slides. So that again clearly highlight that a lot of the gene variants that control weight gain really work on these subcortical areas in the hypothalamus and in the hedonic system. In this very large study looking at more than 2 million gene variants, they designed a polygenic score, and then they divided the score into quantiles. Quantile 10 is basically people who've got the highest number of gene variants related to obesity. Quantile 1 is basically the people who've got the least number of gene variants related with the obesity. And what you see in the study, if you focus on this figure here, where my laser pointer is, that by the age of 18, people with children or early adults who have the highest number of genes related to obesity are about 15 kilograms heavier than early adults or children who had the lowest number of genes related for obesity. Again, showing that those work very early in life in terms of determining different weight trajectories. And when they followed up these people longitudinally, and they looked at the risk of developing severe obesity on the y-axis here, which is defined as a body mass index above 40, you can see that those with the lowest number of gene variants related to obesity almost had no chance of developing severe obesity over 25 years. While those who have the highest number of gene variants related to obesity have got much higher chance of developing severe obesity over 25 years. However, what that tells us two things. One, that this is surely not a willpower issue, because in fact, we know from many surveys that people of normal weight do neither try to gain weight, nor they try to lose weight. So they're not working hard to maintain that weight. That weight is just there naturally. On the other hand, these people gained weight despite trying to lose weight. However, the other thing that this shows is that this risk is not 100%. In other words, that those gene variants related to obesity do not make you definitely going to develop a BMI above 40, but they increase the risk significantly. What that means is that there are other factors at play, and those factors are related to the environment. So we know, for example, for many, many decades, that monozygotic twins have body composition which is concordant. They look identical, monozygotic twins in terms of body composition, while dizygotic twins look less identical. And that also shows the relationship between the genes and the body composition. And if you look at the systematic reviews that looked at the twin studies and examined the heritability of weight and the role of the environment and the role of the genes, these studies will show that about 40 to 70% of any person weight is actually heritable, i.e. it's related to their genes, while only 20 or to 30% are related to the environment. And if you compare that with height, which is we all believe is very heritable, is about 80% heritable. So weight is less heritable than height, no doubt, but is not that far off. But everyone will believe height is heritable. Very little people who are not obesity experts believe that obesity is heritable. And that again goes back to the lack of understanding of the disease pathogenesis and also the disease stigma. And the heritable triad between twins is quite remarkable in terms of energy intake, response to satiety, and basal metabolic rate, as well as response to exercise. And in one of the studies, they showed that even if you take twins, monozygotic twins, and you raise them in two separate families, completely apart in two different countries because they are adopted, they will still have actually very similar BMIs. And their BMIs will correlate with their true parents, biological parents, to a higher degree than the correlation they have with their parents who raised them up after the adoption. Again, showing the very strong component of biology driving this. Another important aspect is maternal programming. So in this study, they looked at the mother weight at the time of pregnancy, and they divided it into 4 quartiles. And they looked at the change in the weight in the offspring between the age of 17 and 32. And what they found is that with increasing weight with increasing baseline weight before pregnancy, there is increasing weight gain in the offspring between age 17 and 32. And they found similar results when they examined maternal weight gain during pregnancy and changes in the offspring weight between ages 17 and 32. But there was a stronger relationship with the maternal BMI at the time of pregnancy. Again, it just shows that not only their genetic scores, but also post-translation and the maternal programming can also have a very important impact on how the hypothalamus will handle the neurohormonal signals that drive appetite regulation. And that all is related to the in utero environment. And in order to understand how the gene and the environment interact, I'm going to show you just one example. But there are many, many examples in the literature. In this study, they looked at 32 gene variants and they designed another genetic score. And they divided them into quartile. Quartile 4, higher number of genes. Quartile 1, lowest number of genes. And they've done pooled analysis from multiple studies. So we focus on the one on the right-hand side of the screen. What they did here is they modeled what will be the BMI change in response to one serving of sugary sweetened beverage per day over 4 years period. And what they found here is that in people without, apologies for this, what they found is that in people who have the lowest number of genes related for obesity, there was actually no weight gain as a result of having the sugary beverage, one beverage per day. On the other hand, there was a significant increase in BMI in those who have got the highest number of genes related with obesity. And you see a grading between depending on the number of genes. So what that is showing us is that even when we fix the amount of calories and we model the changes in weight, we see differences in weight changes depending on the genetic background of the individual in response to the same calorie load. So in order to understand the obesity pandemic, it's important that we understand this in a historical perspective. So we all have our genes, which comes from our mothers and our fathers. And there is like a genetic lottery. We don't know what genes we will get from the father and the mother. But over millions of years, the humans lived in an environment which does not have enough food. And hence they were designed to store energy. And in fact, storing energy would have added a survival advantage. And that's why we have too many people who have obesity now. But when there is lack of food in the environment, regardless of the genes, people will remain lighter in their weight. There will be variation in the BMI, but people will remain lighter in their weight. However, when there is an environment that is obesogenic, like the environment that we have now, then this obesogenic environment will result in will modify the impact of, will interact with the genetic background and will result in different phenotypes. Some people who don't have the genes remain thin. Some people who have a lot of the genes related to obesity will develop obesity, and some people in the middle. So this shows the genetic environment interaction, how it is necessarily to have the environment that promote obesity to see the effects of genes related to obesity. In other words, you can think about it as genes load the gun and the environment fire the gun. If you don't load the gun, the environment will have no impact. And if you load the gun and not fire it, also you will not cause harm. You need to have both. You need to load the gun and fire it to cause harm. And that's the genetic environment interaction. So I've shown you that a lot of the gene is heritable, a lot of the weight is heritable, but obviously not all of the weight is heritable, as I discussed. And that means we can still work to actually help people lose about 20 to 30% of their weight, which is not controlled by their genes. And that 20 to 30% weight can have major impact on health and well-being of the individuals. Having said that, it's really important to acknowledge obesity stigma as a major barrier to deliver care for people with obesity. In a survey in the UK done by the All-Party Parliamentary Committee, 88% of people with obesity said that they were stigmatized during their lifetime as a direct result of obesity. And the more worrying statistics, even that only 26% of people with obesity felt that they were treated with dignity when they sought help from their healthcare professional. So if we can't treat our people with dignity or our patients with dignity when they come to seek help, then we are really failing them and we are not doing our job properly. Every patient deserves to be treated with dignity even when they seek help for obesity. And unless we address the stigma within the healthcare system, it's difficult to see how we can improve the care for people living with obesity. But then the other argument that people usually say, but surely people, when they have obesity, they need to lose weight by eating less and moving more. And this is their fault if they don't lose weight. It's their lack of motivation and the lack of willpower that drives this. I'm going to say no, it's actually hormones and changes in basal energy expenditure that drives this weight regain. And as I said, that historically we are designed to conserve energy because that will give us survival advantage during time of famine. For millions of years, famine was the biggest killer for humans. Now we have too much food, but it's only the last 5 decades. So our genes and our biology has not caught up with this process as yet. And in fact, in many studies, including UK and many other countries, showed that losing 5% of weight is fairly common and easy, but most of that weight is regained between 4 to 7 years. So even a 5% weight loss, which is modest but clinically important, is regained in the vast majority of people over 4 to 7 years. And when I say the vast majority, I'm saying about 80% of people. So why 80% of people regain weight? It's because, again, the hypothalamus is executively sensitive to weight regulation. So when there is reduction in weight, the body reacts by having reduction in satiety hormone and increase in hunger hormone. It also reduces insulin, another satiety hormone. You also get reduction in leptin because of the reduction of fat mass, and leptin is a satiety hormone. Also, leptin drives energy expenditure, so the drop in leptin reduces resting energy expenditure. The combination of these factors is that you get increased hunger and desire to eat, which make a person eat more, and because of the reduction in resting energy expenditure at the same time, then people regain weight. And if you want to put figures on this, then there is a very nice review that tried to estimate these in terms of calories. So for each kilogram lost, the resting energy expenditure drops by about 25 calories a day per kilogram. And the appetite increased by about 95 calories a day per kilogram lost. So imagine that every day, these people are burning 25 calories less per each kilogram lost, and they have an appetite of 100 calories extra per day for each kilogram lost. It's not surprising that they regain weight. This has nothing to do with their willpower. They're actually trying their best to lose weight, but they can't because the biology is against them. Because the body defends its fat mass at a certain level, and it really doesn't like that fat mass to drop. So when this fat mass drops with interventions, it tries to push us up again, but we try to fight it by lifestyle behavioral intervention. And when that doesn't work, we try to fight it even with more powerful tools, such as medications. And then we try to fight it more even with bariatric surgery in order to keep that fat mass set point at a lower level and allowing the body to settle at a new level rather than keep fighting back to go back to the same level that was before the treatment started. However, it's important that at the end of the day, up till now, there is no quick fix solution for obesity. The combination of lifestyle interventions, behavioral interventions, pharmacotherapy, and bariatric surgery is absolutely essential. And in order to have a successful weight loss treatment, we need a treatment that can reduce the appetite, and hence people lose weight. But at the same time, it needs to increase satiety and reduce hunger. I.e., at the same time, it needs to fight those neurohormonal mechanisms that usually drive the weight regain. And having such a treatment that can reduce energy intake and then also keep the neurohormonal mechanisms at bay is absolutely essential for a successful weight loss treatment. And as I said before, modest weight loss can have major impact on health, with greater weight losses even having greater impact on health. Lifestyle intervention is the background of all weight management. We know that. Having said that, with having obesity complications, then pharmacotherapists start to have a play. And with more severe complications or with heavier patients, then bariatric surgery have a major role to play. Currently in Pakistan, there are 2 pharmacological agents available or approved, orlistat, approved rather than available, which is orlistat and liraglutide 3 milligrams. Orlistat works by energy wastage. It reduces absorption of fat from the gut by about 30%, resulting in decrease in energy absorbed to the body. Liraglutide reduces energy intake by suppressing appetite. The weight loss with the liraglutide is about 8% in the scale randomized control trial in the first year, and it continues as long as the drug is being used, and the trials are up to 3 years. On the other hand, orlistat is about 10.6 kilograms weight loss in the first year, with less weight loss year after year during the follow-up. There is safety data about cardiovascular outcomes from liraglutide in people with type 2 diabetes, and orlistat improves multiple cardiovascular risk factors as well. Orlistat is given 3 times a day. Liraglutide is given once a day, but it's injectable rather than oral. And obviously, orlistat is usually poorly correlated because of multiple side effects, including oily spotting, flatus, and diarrhea. Liraglutide, the major side effects are GI-related, mainly nausea, which usually settle over time and can be managed if we titrate the dose slowly. So what does liraglutide or Saxenda liraglutide 3 milligrams do to appetite? First of all, it needs to be noted that liraglutide 3 milligrams is 97% similar to human natural GLP-1. It works by increasing satiety and reducing hunger, and that results in reduction in energy intake. It works on multiple receptors in the brainstem, in the hypothalamus, in the gut, and in the pancreas, amongst others. And it can result in about 8 centimeters waist circumference loss. And when it's combined with low-calorie diet, intensive low-calorie diet with exercise, the weight loss can reach 12.2% on average. And that weight loss is sustained for up to 3 years, which is the longest trial. And with the Saxenda, liraglutide 3 milligrams, it's important to note that people who do not lose 5% by 3 months of treatment are unlikely to achieve 5% weight loss by 12 months, and hence probably it's wise to stop the treatment. However, in those who achieve 5% weight loss by 3 months are likely to maintain a significant, clinically meaningful weight loss by the end of 12 months. And half of these people who achieve 5% early on with Saxenda can reach more than 10% weight loss at 1 year. And Saxenda is planned, according to Novo Nordisk Pakistan, to reach you in March 2022, to be used in people with a BMI of 27 or above, if they have obesity-related complications, or BMI with 30 and above, but without complications. And with that, I will thank you very much all for listening, and I hope that you enjoyed the talk, and it's time for questions. Thank you.
Dr. Tahrani is live with us, so if
thank you very much for a very detailed talk. I have a few things in mind, but I'm going to ask you only 2 questions. What is the highest BMI you have used this Saxenda in? And secondly, have you used it in a post-bariatric surgery patient who have regained weight?
Yeah, thank you for the question. The highest BMI from memory, that is, that I've used it in, it was about 64 or 63. The use after bariatric surgery in people who have weight regain and who have no surgical reason for the weight regain, and also there is no obvious big important lifestyle factor to address. In these patients, I've also used liraglutide 3 milligrams in these people who have weight regain after bariatric surgery. If they have type 2 diabetes after bariatric surgery, I also used other GLP-1s related to the type 2 diabetes management.
It's Umar. Nice to see you, and a nice beard.
Nice to see you.
By the way. Okay.
Thank you.
Just a question. Just a question. We do have semaglutide now, though we are going to using it as an off-license, and previously we were using liraglutide as an off-license for type 2 diabetes. So if you've got sort of basically both of them available, and if I would have pitched that question to you, I mean, which one you would have choose?
Oh dear. Okay. I'm not supposed to talk about off license, but you know, if you talk to the patient and you really want to give it, if you talk to the patient daily injection versus weekly injection, I think the patient views will be probably more in favor of the weekly injection. I hope that answers your question indirectly.
Yeah, that's a direct question. I mean, you will very soon maybe getting question from the no higher authorities, I would imagine.
Thank you, Dr. Tahrani, for the excellent talk. Since you are an obesity expert, I just wanted to ask, what is your view regarding childhood obesity, and what interventions we can do to deal with that, and how big a problem that is?
Thank you for the question. Obviously, childhood obesity is really a big challenge because of largely the limited treatment options, and also because of the huge health impact. For many children, the impact of obesity on their health is very significant, and obviously for many of them, it lasts throughout their adulthood years. So, and also obviously associated with a lot of social stigma, bullying in schools, and many other unfriendly social situations. So I think it's definitely an important subject. So there are multiple interventions which are being developed specifically for kids, even for younger ages who have obesity. And as you know, for example, for young kids who have specific genetic monogenic forms of obesity, there are drugs approved outside Pakistan, like setmelanotide, for example, which is approved for weight loss in certain monogenic obesity. Also, there is approval for Saxenda in a certain group of children. And there is more studies are ongoing for lower ages and with different products. So I think there is more and more scope, of course, for pharmacotherapy in childhood obesity, but currently it's a little bit limited, but it will open up as time goes by. And obviously there is bariatric surgery in adolescence. The data about bariatric surgery in adolescence is actually quite strong, but obviously again, the availability of that is extremely limited.
Dr. Abd, over here. I'm Dr. Sama, and I need to ask, have you ever tried using this drug in patients with PCOS? And what benefit would you expect from it, especially in terms of their menstrual disorders as well as fertility? Thank you.
Yeah. So as you know, women with PCOS have a high risk of subfertility, and some treatment options are also not available to them because of the excess weight. So for example, in the UK, if the woman has a body mass index above 35, then ovulation induction is not available. And if the woman have a BMI above 30, then IVF is not available. So many of these women would like to lose weight to improve fertility, of course, but also if not improving fertility, improving access to treatment that can improve fertility and achieve pregnancy. And indeed, we have used semaglutide and other agents as well before. Sorry, not semaglutide, liraglutide, 3 milligrams Saxenda in women with PCOS in order to help them lose weight. We used other agents previously as well to help them lose weight in order either to get pregnant spontaneously after weight loss, or that they drop their BMI below 35 or below 30 to get ovulation induction or IVF. But it must be noted that while they are taking these medications, they cannot get pregnant while they are on the medication. So they need to ensure that there is enough contraception or adequate contraception at the time. And depending on which agent you are using, you need a washout period after that. So for example, just to give you an example, for liraglutide 3 milligrams, we usually advise that they should stop they should have a period of about 4 weeks between stopping the drug and getting pregnant or attempting to get pregnant.
It's Dr. Shoaib again. I wanted to get your view on sugar tax and whether that is an appropriate method to control obesity at a population level.
Yeah, so thank you for that question. Yes, so thank you for the question. On its own, as a sole measure, the answer is simple, is no. It will have very limited impact. However, if you look at that complex figure which I've shown you before, which shows the map and multiple factors, then the answer, the sugar tax is one piece of the puzzle. I.e., if it is part of a wider system-wide intervention, then it will have an impact on reducing the burden of obesity on a societal level, and also it will play a role in preventing, in obesity prevention. However, for somebody who have a BMI of 35 or 40, sugar tax will have really very little impact. But as I said, it has to be a part of a wider intervention, not just as a single intervention on its own.
Okay, I mean, thank you very much. I think in interest of time, we have to move for the next presentation. So thanks again,
no problem.
And hopefully we see you
Lovely to see you
somewhere in Birmingham.
Take care. All the best.
Thank you.
So the question was directed towards our presenter. I don't know if he's back online or as not, or I will direct the question towards the panel. I would like to add, what if we add Saxenda to a patient who is type 1 diabetic and has obesity as well? And would it benefit type 1 diabetes as well? Because type 1 diabetes, apart from losing the beta cells, there are other mechanisms where GLP are also acting. The ominous octet, all of it is being addressed through GLP.
Okay.
So your experience on that.
Yeah,
Thank
so
you.
I can answer you better than Abd, because this is something that I've actually studied while I would start with Abd. So with type 1 diabetes, there is very modest improvement in postprandial hyperglycemia. That's how it acts. I mean, people have tried, especially in Wolverhampton. So there was a Dr. Singh who have tried, who have got some studies on use of liraglutide in type 1 diabetes. You'll see 0.2 to 0.3% reduction in HbA1c, mostly due to postprandial effect. And that's the reason we don't use it typically in type 1 diabetes. So you are saying, I mean, in case of say double diabetes, sometimes people, and if they are gaining weight, so yes, you can try it, but then again, the indication will be purely weight loss. I will not be surprised. I'm not going to be think about using it for in terms of the HbA1c reduction, though I have a feeling that it might have an impact on the glycemic variability. So it's the same thing like dapagliflozin. We use 5 milligram purely not from the HbA1c reduction point of view, but maybe to improve glycemic variability. And with that glycemic variability, you are going to see that there is slight, or there's a better reduction in HbA1c per se.
We'll be moving on to our next talk. This is how to set up an endocrine bariatric clinic by Dr. Rahila Bhatti. A few words about her. She's currently working as consultant endocrinologist at Mediclinic City Hospital, Dubai, UAE. Dr. Bhatti is SCOPE certified and has developed weight management program in a multidisciplinary setting to deal with obesity epidemic in UAE. It has been accredited as Clinical Center of Excellence by European Association for Study of Obesity in August 2020. She is now clinical lead for Dubai Medicine Weight Management Program. Dr. Rahila.
So I think Dr. Tahrani has set up the scene that obesity is a chronic disease. And after my talk, Dr. Raza is going to talk about bariatric surgery. So I thought, what is my role as endocrinologist between this medications and the bariatric surgery? Because we all talk about bariatric surgery. Nobody wants to talk about obesity. So what is our role? So I thought, let's talk about from bench to bedside. So I think we need to change our thinking as endocrinologists. And maybe we can work hand in hand with the bariatric surgeons. And we need to think about of a newer term, just like we talk about diabetes and obesity, and you must have heard of the term diabesity. I think we need to talk about bariatric surgery and endocrinology, and maybe we should come up with something like baricrinology. That's what we need to think about, but we need to think and change how we perceive obesity as a disease, and then we can think about setting up a service. And this is what the topic for my talk is. So I'm going to give you a little bit of background, how we endocrinologists can assess our patients, and then the journey of, well, to take you through the journey of how we set up the clinic where I work, and sharing my experience and what have been challenges on the way of this journey. And then we will talk a little bit about the certification. So I work in Dubai, and that is why this is the first slide I've put up. So what is the problem? Why did I want to work as an endocrinologist in weight management? This is the reason. We all know that diabetes is very common. So 1 in 5 patients in UAE, they are diabetics, but 1 in 3, which is 30% of people are obese. And this is 2017 to 2018 data. And I think the COVID pandemic has not helped any of us. And I think we will see a big rise in these figures when the 2021 data comes out. So Dr. Tahrani kindly put up the Pakistani slide, and I think the population is similar. So what we are dealing with UAE, I think Pakistan is dealing it with the same. So if he's saying that it is 40% here according to the data, this is 2018, which is 30%. And at this stage, I would say it is close to 40% in UAE. So if this is the problem, then what we need to think about is that what is the first thing that comes to you as physicians? What can we do? When we see these patients, and I'm sure everybody sees these overweight, obese patients, it's not that it is not out there, it's just that the stigma is attached to it, and there are other perceptions as well, both from the patient and the healthcare professional point of view. So I thought in my head, okay, can't do it alone, because I think endocrinology is one field where we all work together. in diabetes as well as endocrinology. So what about obesity? So I thought about, okay, so we are physicians. Then, yes, we need dietitians, isn't it? Then we have bariatric surgeons. Without that, it won't work. Then we have gastroenterologists. Then yes, surely we need patients to treat as well, isn't it? So in my head, I thought, okay, we need to do some solution. We need to bring up some solution because there is a big problem. At least we all accept there is a problem. So what can we do about it? So what I thought was, okay, why don't we do a collaborative approach? Let's think it from a different perspective now, okay? Let's think of just like we do for cancers, isn't it? In cancer, nobody would deny the fact, okay, we surgeons will work, the physicians, the cancer specialists, you've got a full team, yes? You will need surgery, you will need radiotherapy, all the modality treatments, they all work together. What if you have a similar model in obesity? How can that model be? So we will have the diabetes, we all work with diabetes. And like I've said, obese patients, the majority of them, they are pre-diabetic or diabetic. So we have the doctors, the nurses, the dietitians. Then in Dubai, we need, or I think that is true for here as well, we work very closely with our management, wherever we work in the private or in the government setup. We need to work with our chest physicians. Why? I'll come to that. Okay, bariatric surgeons, the bariatric anesthetists, gastroenterologists. So it has to be multi-speciality. I think we all agree with that. It has to be multi-level, multi-speciality. It has to be multidisciplinary. If we want to do it properly, the weight management, it has to be multidisciplinary. But I think if we have a collaborative approach, yes, we all work with each other, but I think we need to move away to a patient-centered approach. I think it has to come away from us physicians or surgeons or saying, okay, I'm going to do this or I'm going to do that. I think it should be patient-centered. So patient has to be in the center, and he is, whether we accept it or not. And then we all need to work around that patient to help that patient in treating this disease, because it is a disease at the end of the day. So it has to be a patient-centered collaborative approach. So we have all seen that for these overweight, obese patients, we have got all these modalities which are available to us. So yes, the exercise and the lifestyle intervention, that does make the foundation of any weight management. And then we need to think about, okay, yes, pharmacotherapy is available. And we need to think about along these BMIs, because that's what the American Diabetes Association tells us. And if you look at any of the international guidance, it is based around the same concept. But I think in this population, we probably need to do something now, because I think even this is not true for our population. I think everywhere you will see, yes, above 25, it is obesity. But is that true for our population? We are more talking towards, okay, maybe 23 is the normal for us. We still don't know, but there's a lot of talk and research going into this, that for the Asians, what is the best BMI that we should be at, where it does reduce our risk of cardiovascular disease or mortality. So we have got all these modalities available, and this is what we have based our program on. So this is what we are following at the moment. So EASO is, which is European Society for Obesity, for clinical obesity. They have published this in the Obesity Facts, and it's quite a good document to read actually, because it tells you how to set up a service or what should be in that service and how can we manage our patients. So it talks about all these overweight or obese patients who can be seen in any setup, but we need to have clinical pathways. We need to have an infrastructure that all these things should be made available for our patients. So this is a very good document to read, which tells us that how can you achieve a center of excellence, or what should be there? And actually, what is center of excellence for these patients, where they should be treated? So now I'm going to take you through my journey, which I've been taking for the last 3 years. And it started off at Parkview Hospital, which is a private Mediclinic hospital. It has been 3 years since I moved from UK to Dubai, and this is what I started. And I would just like to take you through that, yes, we started from scratch, but what we have achieved in these last 3 years, and that's what I wanted to share my experience with you. this is how it started in 2018 for me. I started with the diabetes endocrine clinics, and that's what I was doing basically. And then we were visited. So one of our bariatric surgeon colleagues brought in two of very good international known figures. So these are the two bariatric surgeons, Dr. Jamie Pons, who was one of the presidents for the American Metabolic Bariatric Surgery. So they came and spoke to us, and we had a very good discussion. So this is our team, you know, the gastroenterologist, we had the management, we had exercise physician, dietitian, all of us, we sat together and we thought, okay, they said, you know, you have got the team, you just need to make it work together. You're already doing bits and pieces, but everybody is doing it independently. So they shared with us, okay, what you should be looking out for, or the tips that they gave us. This is how we started off. And then it was evidence-based. So this is my team. We met outside. This was December 2018. We met outside, and you know, all the team is there. Well, we can't see it here, but they labeled me as sugarholic because I was the diabetologist. But then we had the gastroenterologists who were labeled as balloon busters because they do the gastric balloons, and the bariatric surgeons who were labeled the shredders. So we all wore these, but it was for team building. That's what this exercise was for. And this is where the journey started. And we had the discussion and we thought, okay, what will work out best? Yes, we know from the West, because there's a lot of scientific data there. We do data collection. We don't have that luxury, or we don't have that to the same level as in the West. So the problems are similar to what we have in Pakistan, I would say. I think it is ongoing, research is ongoing, but at this stage, we didn't have that data. So what we did was, we came up with the Mediclinic hospital weight management program. This is how we started off. So we said, okay, we are going to all work together, and we prepared a document. Okay, we thought, okay, if I am the patient and the patient comes to me in the clinic, what am I going to do? And what is the role of each person, and how we can make it easier access for the patient? Because remember, it's patient-centered approach. So I'll talk you through this. So we established that we have a call center where patients will call in and they will book, okay, I want to see this specialty, or I want to see that specialty. And we said we have made the dietitian as the coordinator for this program. So the call will be directed to the dietitian. You need a coordinator to run these programs, because otherwise it will all fall apart. And we thought the best person will be the dietitian, because whatever modality we'll choose, the lifestyle intervention with the dietitian is going to be the center for this process. So the patient calls in, or we have a dedicated email address. So the patients, they can directly contact through that process. And then the first port of contact will be the dietitian and the physician. So both of us, we work closely together. Now the patient doesn't need to see everyone in the team, right? So we do the first assessment and we say, okay, it's the first initial assessment from the physician point of view. Is there any underlying endocrine problem for the weight gain, and all the things that Dr. Tahrani spoke about? Why, what is the reason for the obesity? Spending the time with the patient, figuring out, is there any eating disorder? What is it that have changed for them over their lifestyle, or something that is in their history? So history is again the key, as with any other disease. And then we do talk about what are the complications. So first we have done the assessment, and the dietitian has done the assessment. We actually see, okay, has the patient any symptoms of reflux, or the patient needs to be seen by the gastroenterologist? Does the patient have any symptoms of obstructive sleep apnea? Yes, the patient will be seen by the chest physician. So we try and book all those appointments for the same day for the patient, or within that week. The patients who do require bariatric surgery, they are then seen by the bariatric physician. And then the patient who will go for any gastroenterological procedure, they will just get seen by the gastroenterologist. The gastroenterologists, they are also, well, the ones that I work with, they are also trained in medicine. So what they will do is, if they've seen them, sometimes we don't need to see them, depending on what the problem is. So one patient does not need to see the whole team. We decide, or the dietitian or the coordinator can make that decision after discussion with a physician, which patient needs to be seen by which specialty. And then we put them back in the loop. I think the most important thing is the follow-up. The follow-up either after any medical intervention, any lifestyle intervention, or any surgical intervention. So we have made this pathway that if any bariatric surgery done, any case that goes for the surgery will have to be discussed at the bariatric MDT. So we just run one MDT where all the cases that are going for the surgery, we all sit together. So it is attended by a physician, a dietitian, gastroenterologist, and the surgeon. And then we discuss, and then they decide, okay, is the patient adequately prepared, or psychologists if needed. So patients get seen, and then they will go for the surgery, and the follow-up is basically with the dietitian. If the patient has other comorbidities, then the physician will be following it up, and by the surgeon. So this is the pathway we are doing at the moment, and I think we have developed it over the 2 years, learning from it, from our mistakes, and then we have just revised it in that way. So as bariatric, as a endocrinologist, what we do is, we do have the luxury, I would say, of doing the anthropometrics. So what that means is we're trying to move away from just the BMI-centric approach. And what we do is, it's simple things which we can do in the clinic, because what we are all trying to do is, what is the fat mass? What is the visceral fat for this patient? And it's a simple old tool, the waist circumference, which we can all do easily in the clinics. So we do that. We, the dietitian, she will put the patient on this machine. It does the body composition for us. And then she will have a discussion with the patient about the eating behavior. And we also do provide the cognitive behavior therapy as well, which is also a part of this. Behavior therapy is plays a very key role in majority of these patients. So once we have done that assessment, seen by us, other tools that we are using for the clinical assessment is visual. So, showing the patient, really not only talking to them, okay, you can have one roti, or you can have this much chawal, you can have actually show them on the plate how much they need to do for it to be beneficial to them. Then we also show this, how much fat is in them. And this gives a visual, I think, more for the benefit of the patient. It makes sense. Oh, actually, I'm carrying this much fat. And the same goes with we are using these different applications which are available online or on the phones. Everybody's carrying phones nowadays. So yes, maybe we have made use of it. And this anthropometric measures. So once we have done that, we actually sit with this in front of the patient and we tell them, okay, this is where the problems are. Is it the water intake? What is the basal metabolic rate they need to reach to actually lose weight? And whether they are losing the visceral fat or the muscle. We don't want them to lose the muscle mass. So that is this tool actually helps us with that. And like I said, I use it clinically. When we don't have all this, we use the waist circumference. Simple measures to the waist circumference, hip circumference, and you can easily judge, okay, what is the waist hip ratio and where we are going with that. Then the next thing is we have signposted everything. And I think we didn't want to put it as a bariatric or obesity, because I think that word itself has stigma attached to it now. So we do point the patients when they are coming in. It is signposted where the dietitian is, where the endocrinologists are. We have made sure now that we have got wide chairs available. Patients that come in and they sit at the edge because they can't fit into it. And, again, the stigma is attached, how they're bullied with all that. And I think, then they are either standing in the waiting room, and we don't think of these things, but from the patient's perspective, they might not even want to see you then because, oh, I can't fit in, let me go home. So I think we need to break that barrier and say, okay, what can we do to help them in thinking, yes, it is a disease, then they have come there to ask for help, and what help can we provide them? So then we have looked at our data from the first year. So in the first year, we saw in our clinic about 300 patients. Majority that we saw were females. And there are more than 50% of the patients, they are Asian or Arab in origin. You need to understand that UAE is actually quite multicultural. Only 10% of the population is local. The rest is all expats like us. And then we looked at gender specific, what is their baseline BMI. Majority that we were seeing were BMI of about 34. And we then saw what the visceral fat was actually higher in males. The fat mass was higher in males.
Dr. Rahila, just a couple of minutes, we're just running late.
Okay. Then there was a metrics that we did just to show that there's a strong correlation between the BMI and the waist circumference, and also the BMI and the visceral fat. So this paper we just got published. It's available on PubMed. Now we have looked at our bariatric surgical outcome data. We did 69 patients. Majority of them were females. Majority of the procedure that we have done is sleeve gastrectomy. And we have shown that from the baseline BMI of 41, they have actually reduced to 32 at 6 months. And the rest of the data shows that the waist circumference and the visceral fat has reduced. Same goes with the laboratory measurements. The fatty liver disease has improved, and it is statistically significant. Patients who were pre-diabetic, they have normalized their blood sugars. We do run a program similar to what we have here, just to raise awareness between our colleagues, because the biggest problem is the awareness. So we do it with the healthcare professionals, and we do run annual weight management symposium. This is our team. We have gone to our cluster clinics, which are like a primary care clinics, to raise the awareness so that they can send patients to us. This is working with the gastroenterologist who does the endoscopic sleeve gastrectomy, and our surgeons. Then we do run challenges for our staff within the hospital. And this is like healthy eating. And we have done the winning loser. So who loses the most weight in 1 month, they get a prize. So we make them work out in the lunchtime. So small activities, simple things. These are all our physicians, even including the medical director, who we have made them sit without the chairs, just activity during the lunchtime. So the challenges have been a lot, I would say, but I take them as opportunities, and I think we learn from it and we can change. So it was getting the right equipment, convincing the management, yes, we do need wide chairs. We do need wide couches for the assessment of the patient. We are affiliated with Mohammed bin Rashid University, so we do get students and teach them. And we have built up a patient support group. And to raise awareness in the public, we have been doing the Zoom sessions, which are open to the public forum, and we answer patients' questions. And the questions that we get there, it's amazing that what the myths are around what people think. Is it thyroid? Is it my insulin resistance? That's what I blame for my obesity. So we try and have that conversation with them and guide them appropriately where they need to go for help. And we are auditing our service, closing the loop so that we can improve our service. And the next step is that we want to make it for the whole Mediclinic group, that we want to apply for Center of Excellence. So this is the European Society of Obesity, which has made these Center of Excellence in the whole of Gulf region. There are only 2, one of which is us. And I just wanted to say it's more than just a certification. And I think that's why we are all here, because we want to manage this disease. So I just want to thank you, my whole team, who has helped me in getting to where we are at the moment. Thank you.
Okay. In the interest of time, just one question, burning question. That's fine. Thank you, Dr. Rahila. Dr. Rahila will be available at the end of the session, so you can always ask any question regarding him.
So moving on to the last talk of the session, do's and don'ts of bariatric surgery, surgeon's perspective by Dr. Javed Raza. Dr. Javed Raza is a bariatric surgeon and is the director, bariatric and metabolic surgery, Cleveland Clinic, Abu Dhabi. Dr. Raza has multi-center, multinational training. He's been trained in advanced laparoscopic and bariatric surgery from UK, Netherlands, and California, USA. He has an experience of developing 4 bariatric surgery centers in UK and Abu Dhabi. He has also been part of the group to develop bariatric surgery guidelines for UK. He has been author of book chapters on bariatric surgery and has published numerous articles in peer-reviewed journals. Dr. Javed Raza.
Thank you very much. Coming to PES is like coming back home, and I'm very grateful to my dear friends in Pakistan Endocrine Society. It's a great honor to be here year after year and to share some of the experience, but also to enjoy the lovely hospitality and company from my dear friends. When I was given this topic, I thought I can make a list and tell what to do and what not to do, but then I thought, they're not going to pay for my journey and hotel just to get a list. They've given me a tough topic, and I will try to see how can I do justice to this? Now, we had some wonderful discussions and presentations today. And you know, when you go and buy a perfume and when you've tested a few, then you can't make the difference. So you smell coffee beans, yes? So I'm going to change the scene a little bit. This is when we went for PES in Naran. And this is a glacier. Let me see if we can run this video. So this is our coffee bean. And then I went with Professor Amir. We went to northern Pakistan. I always like to bring slides of my country, even when I'm talking abroad. So this is mighty Indus with two great mountain ranges on both sides. This is Swat River on my way to Kalam last month, and then Naran in the background. So let's come back to our topic. So the perceptions about obesity and what people can promise. Paul McKenna, I'm sure most of you have heard about it. I can make you thin in 7 days. And these are the claims that you can make people thin and they make them look beautiful. But there is a twist in the tail. And people don't usually talk about the downside, the reality of what can happen. So coming back to what is perspective, and I needed to know this, so I dug it up. It's a point of view or way of looking at things, and it's a product of influences in your life. So I can't give you the perspective on this unless I can tell you about my life. If you're a hammer, everything looks like a nail. So I'm a surgeon, I want to operate. I'm an endocrinologist, I want to give medicines and fix people. But then perspectives can change. So unless you move, you will not be able to look at the other person's perspective, and you're both right. So on the left, if you're standing on the left, you are correct. And if you move to the other side, then your partner is correct. And you only will have a balanced perspective if you have kept that capacity in your mind that there can be a different view. So looking at a sort of a typical surgeon, my operation is the best treatment. I'm the best surgeon. I don't get any complications. By the way, this is not me. I'm just putting a prototype up there for discussion, and so on. So I graduated from Peshawar, and looking at perspectives, the picture on the bottom is actually University of Peshawar. I would have thought it was a Vienna or somewhere. And then I trained in Ireland, then went to UK. That's where I spent about 20 years. I did my fellowship in bariatric surgery. And the reason I'm talking about this, because this is creating my perspective of bariatric surgery. And I went to US and Holland. And the three places that has influence on my perspective is Royal Derby Hospital. It's a 1,200 bedded hospital. That's where I developed my first multidisciplinary bariatric program. I developed two further in UK, and then I moved to Cleveland Clinic. That's where I've led the service and developed my fourth bariatric program. And the building at the bottom is my passion. I'm a vice chairman of Midland Doctors, which is a 90-bedded charity hospital. We've been running it for the last 10 years. And this is me. I live in Abu Dhabi with my family. My older son, he's 25. He has special needs. I'm blessed with a very loving mother, and I'm very close to her. And from mountains of Pakistan to sands of Abu Dhabi, I try to enjoy everything. This is yet another adventure with my friend sitting here. When we traveled up north, this is Nanga Parbat. And this was past 4 years ago. I like music, especially Sufi music, and we had Fateh Ali that evening, and it was a fantastic evening. And I absolutely loved watching cricket in Abu Dhabi. So I developed the bariatric program from zero. The hospital was new, and I'm fortunate that I work in a superb hospital, which is very resourceful. And we started with the program. At the beginning, we offered sleeve gastrectomy, gastric bypass, and revisional bariatric surgery. Now, we offer a full range of bariatric surgery that is available anywhere in the globe. So that involves the robotic surgery, the endoscopic sleeve gastroplasty, the endoscopic stents, balloons, SADI, all that. And as per my previous colleague who spoke about it, I believe to the core that you cannot function as an individual without a strong team around it. And it is your responsibility to build that team. And it is important to look back and see what you have accomplished and celebrate that and share it with your friends. So this is in Cleveland Clinic when we did our first 100 cases, then 500, and then 1,000. We are, inshallah, going to celebrate our 2,000 bariatric cases in Cleveland Clinic. Alhamdulillah, we didn't have a mortality. It is our responsibility to report our complications. So we are part of the MBS script, which is an American quality program. All our bariatric operation data non-selectively goes to this American group, and we report every single complication. I also report my data to the Department of Health in Abu Dhabi. This is how from 2015 September, I opened the service, and last 3 years, we are doing more than 100 cases per year. This year, we've done more than 600. And this is a breakdown of our monthly, I think March was our highest month with 74 bariatric cases. So as I said, we've completed 2,000, and inshallah, we'll celebrate it soon. Now I want to come to a couple of clinical cases now, bringing back to our perspective of what we should or shouldn't do. So I saw this girl actually last week. So I first met her 1 year ago. She's 17. She has Prader-Willi syndrome. This is a syndrome where kids or people affected, they do not feel when they're full. So they can carry on eating, among other things. So she had sleeve gastrectomy when she was 12. And she had sleep apnea at that time. Her BMI was 52. The weight reduced. She came to BMI of 35. Sleep apnea improved. So this is when I first met her last year, November. And she came, and the mother told me that she was eating chocolates, fizzy drinks. So I said, okay. Thinking of my perspective, what to do and what not to do for this young girl. If you're thinking purely from a surgeon's point of view, you would just go and say, okay, my operation can fix this, let's do it. I've been a surgeon for nearly 30 years now, and bariatrics have been involved for the last 17 years. And I have children, and she's like a child. So I got my dietitian to see her. We sent her to adolescent psychologist, and we fortunately have pediatric endocrinology in Abu Dhabi as well. So those are the do's that you need to do that, and don't was not to operate, not rush to do, don't be that hammer that wants to knock every nail. I saw her last week. She had been seeing our dietitian every 2 weeks, and she has changed. But because of her inherent issue, she has bad sleep apnea, which actually she sleeps in the class, she's in school. Her BMI is 55 now, and she has now insulin-dependent diabetes. She's developed urinary incontinence. So the same patient, the perspective is changing now. Now, if you look in the small print at the bottom, that complicates, small print always complicates things. So I operated on her mother. She had a sleeve somewhere else. She had reflux problems. I did a Roux-en-Y bypass for her last year. And I saw this lady, and she told me that I operated on her mother as well. So this was a third generation. So that makes it even more difficult for me because I have a relationship with this family. So that becomes even bigger responsibility. Now my perspective is that this young girl has genuine problems. I know I cannot fix her long term, but whatever I can do, so I'm getting now reports from pulmonologist, endocrinologist, and I'm now planning to do surgery. I'm going to discuss her case in an international bariatric group, surgeons group that I'm part of, as to people who have more experience of who have done these children. Technically, doing the operation is not an issue, but what to do appropriately is the issue. Because I think of her as my own child, what will I do? And that is the moral compass that you need to use. Another case, 55-year-old, 130 kilograms, BMI 45, metabolic syndrome, possible sleep apnea, cousins, friends had surgery under my care. And patient is on the bariatric pathway, and I met and felt that there was little unease. So he said, well, I'll develop loose skin and this and that. And I said, of course you'll develop loose skin if you lose enough weight. And then I sat and I asked my dietitian, Arabic speaking dietitian, to talk to him a little bit more, because I could sense there's something that I don't understand about this patient. So she came back and she said that he does not want the operation, but the family is pushing him to have the operation. Now that is, my primary responsibility is to my patient. It doesn't matter how much I respect and I have relationship with the family, but my responsibility is that patient. And unless I'm sure in my mind that that patient wants me to do that, or offer that treatment, I'm going to resist the temptation to do that. Now, I'm fortunately working in a system like the National Health Service, where I have a fixed salary and the operations do not determine how much money I get. So I have the luxury of being on the moral high ground. But I understand that finances do come into play when we're treating patients. Another patient who came with epigastric pain. In my practice, almost half of the patients who come to me, they already had some bariatric operation somewhere else. Patient had a mini gastric bypass, which is the picture on the top, where you create a long sort of sleeve and then bring a loop of bowel up to join with that. And this is an operation that is done quite frequently in Pakistan. The patient lost good weight from 90 to 56, BMI dropped to 21. Usually they develop reflux or vomiting, but this patient only has pain. She had endoscopy done elsewhere. And my disclosure is that I don't like this operation, okay, because I feel there's not enough long-term data about reflux, but that's my bias and I'm openly admitting it. Now, my dilemma was that I tell the patient that you shouldn't have had this operation, but that's not what I should do. So I resisted the temptation to do that, and I gave her the options that I can either convert it to a Roux-en-Y, which will divert the bile away, or she wanted a reversal. And I think in do and don'ts in here, I had to stop talking about people who offer this treatment, surgeons, about my colleagues, and then sort of put remarks when they can't defend themselves. And this is the last patient, and I'm nearly 2 minutes from the end of my talk. 28-year-old, BMI 31. Now, this patient had done diets, Botox treatment of the stomach where you endoscopy and inject, which is just a money-making gimmick. There is no evidence that this works. They get GLP-1 agonist with it, and that you lose weight because of that, not because of Botox. She had intragastric balloon, and she tried the medication, and she doesn't like to exercise. She's a self-pay patient. She wants sleeve gastrectomy. So my heart says that she's not going to do well. She's admitted she doesn't like to do exercise. And so this is, if I was in private practice where this patient was bringing in money, that would skew my sort of decision making. And again, this is something that we need to be aware when we're making decision about surgery. So last 2 slides. So my perspective, yes, we need to make money, but we don't live to make money. That is, we all need it, and let's admit, no one dislikes that. All bariatric operations, like all treatments, have a shelf life. You get a valve in the heart for 10 years. When you need a new one, you don't call it failure. that's the life of that treatment. Obesity is a chronic disease, and it's going to need many different types. And as I'm getting older and experienced, I'm realizing that more and more. You cannot function without a multidisciplinary team before and after. And I think Dr. Rahila spoke about that very important aspect of bariatric practice. And my moral compass is that the patient sitting in front of me, if it was my sister or my daughter or my cousin or my brother, would I offer the same treatment to them? And I try to guide myself. We all fail sometimes, but that is the general principle. Endocrinologist, I've got many friends here, and they're not a threat to my business. We complement each other. And I think the more experience I get, I realize when I started, I said I can cure the diabetes. This was 10 years ago. Now I admit I cannot cure anything. I can help to control the diabetes for a decent period, but I'm going to need my endocrinology friends to treat my weight regainers where I don't have surgical options. So I think we all are working to treat this menace of obesity, and we all need multiple tools for that. Every surgeon will have complications. Surgeons who claim they don't have complications, they're either not doing enough or they're not telling the truth. There are social restrictions from bariatric surgery. You can never have a 3-course meal, and I have that conversation with my patients now. Our social life, you invite people, you feed them, you go to someone's house, you get fed. If you don't participate, this is rude. It's even worse in Middle East. So I tell them this will happen. And it's important that you report your data, you have your data, because as surgeons, we tend to overestimate our numbers and we tend to underestimate our complications unless you put them on the paper. And don't have fixed views about an operation. I had fixed views in the early part of my career, but as I'm getting experienced, I keep a little bit of leeway for there could be a different route. And that's why I have an open mind about the mini bypass as well. When you're revising a surgery, don't tell the patient that the surgeon did the wrong operation. There's the day you say it, the next day you will have a complication similar. And don't guarantee outcomes to your patients. And I tell them that this is what my previous patients had. I hope that this is what you will have. And I say, I can't guarantee there won't be a complication, but I can guarantee I'll do everything to fix it. Without an MDT, don't work. And don't ignore the concerns from your MDT. I'm the surgeon, I'm leading the MDT. Yes, my dietitian said X, Y, Z, but I think I should do this. You will regret to do that. And when there's a complication, don't hope that it will get better. You're a surgeon, you have to go and fix it. And lastly, don't compromise. We are in great habit of putting up pictures and patient names, and 500-kilogram patient I operated on, they lost this much, and photos all over. Patients need to have their confidentiality respected. So I think this is last night. I believe that life is too short and we need to enjoy ourselves and be as responsible as possible in that pursuit. I again thank you very much for your attention.
Okay, in interest of time, just one question, and then that's it. So, Professor Amir.
Thank you, Javed. The more we listen to you, the more you will be more a part of us, because what you have actually said is the time management. I thank you for that, being the scientific chair, and you stick to the topic. Thank you very much. Just 2 questions. Quick. What is the youngest patient that you have done in terms of age? 1. And what about this shelf life of bariatric surgery? You know, what to do about it? Yes, it's a fact. What do we do about it? And do you tell this to your patients straight away, that this is the shelf life? I know you stick to you know, the program, that lifestyle management and all that has to come before the surgery and then has to continue. So 2 questions, youngest patient and the shelf life. Thank you.
Thank you. So my youngest patient was 13 when I did her. She was BMI 65. She was arresting at home, cardiac arrest because of sleep apnea. So it's not just for weight. Younger adolescents, I only operate if there is significant health issues. So that is sort of general and with appropriate MDT preparation. Yes. So you need to involve a social worker as well in that age group, a child psychologist, a pediatric endocrinologist. So that's the hard requirement from the health authority in Abu Dhabi. So we need to do that. Secondly, I think I'm becoming more aware of the relentlessness of the obesity as a disease. It's like diabetes. And in my mind, I don't tell it to my patient directly because then they think, okay, it's not my fault. It's the type of operation, and I can have another one. So I never talk to my patients and say, well, we'll do this, and if you gain weight, we'll do this, because then you're aiming for failure. So I tell them this is it, and the example that I give them is that I'm giving you a Mercedes. If you service it, if you park it in the right place, if you don't bump it here and there, this Mercedes will last for 25 years. And if you don't do that, in 2 years, you can destroy the best car. And the second thing I tell them, that bariatric surgery is like going for Umrah or Hajj. The more you prepare, the more enjoyable the experience will be. And this is what I try to convince them, to make the changes before surgery. And typically in our program, no one gets surgery before 3 months. And this is, people told me that you will never develop a practice. People are used to getting operation next day, and no one will come to your program. But alhamdulillah, you do the right thing, I think it comes to you.
Okay, so
Comments from the panel.
because Dr. Javed Raza is a surgeon, he can speak in terms of Mercedes. We as an endocrinologist can speak only in the terms of Suzuki Auto. Sidra, can you please the comments? I will hand it over to my colleague Dr. Sarwar to make comment on my behalf as well. So Sarwar, please.
Excellent talks by all 3 worthy speakers. It is really difficult to engage patients during the last session of the day, but they did it very well. Thank you very much for your excellent talks.
Can I request Professor Saeed Meher to please come on stage and present the appreciation shields? I'd request Dr. Rahila Bhatti to please come on stage. Dr. Javed Raza. Dr. Sarwar Malik.